There's going to be a Cadillac Plan Tax. This is a 40% excise tax on average benefit value, excluding dental and vision, of health plans with a total value to their members in excess of $10,000 for single coverage and about $27,500 for family coverage. There are a number of adjustments. This becomes effective 2018. Again, this excise tax is non-deductible, and obviously, if it actually goes into place, will be a big deterrent on employers or insurers from offering very rich plans. We've got a post-acute bundle, a 5-year pilot program beginning in 2013. We're going to bundle payments for inpatient hospitalization, physician, outpatient services, hospital readmissions, post-acute services, and whatever else the Secretary thinks is appropriate. Episodes of care will start 3 days prior to a hospital admission and end 30 days following patient discharge. How that will affect your segment, I don't know. Initial focus on 10 conditions selected by the Secretary. Program may be expanded after 2015, and as I say, the effect on O&P to be determined. Something a lot of people are talking about all over the country, accountable care organizations, shared saving program for providers and suppliers, serving at least 5,000 Medicare fee-for-service beneficiaries. ACO members or providers will continue to receive fee-for-service payments. This is not Medicare Advantage. This is not an HMO. But that ACOs that meet certain quality targets and reduce costs relative to some spending benchmarks will share in Medicare savings. Now, ACOs may not limit beneficiaries' access to medical service from non-ACO members through pre-authorization or network cost-sharing incentives. So these will become effective in 2012, and it's not entirely clear what sort of implementation rate they'll be. It's more likely that certain regions will do this sooner than others. But there will be some strategic decisions by most provider groups as to whether to join one of these or not. The hospitals most likely will lead them. But the question is, do you or do others in other provider groups want to be part of an ACO or watch the system develop and make a decision later? Federal tax on medical device sales, something near and dear to your hearts, I'm sure, imposes a tax of 2.3% on the price of medical devices, theoretically including O&P, sold in the U.S. after December 31st, 2014. Now, it exempts items intended for further manufacture and also eyeglasses, contact lenses, etc., determined by the Secretary to be of a type that is generally purchased by the general public at retail for individual use. And I know that your association is working carefully with folks in Washington to minimize the effect on O&P from that provision. And then finally, strengthening program integrity. There's a lot more money for anti-fraud enforcement. I think Peter Thomas talked to you yesterday about the RAC program. That's part of this. Authority to require adoption of compliance plans by all providers. The Secretary will be rolling that out over the next few years. Clarification, and this is important to everybody in Medicare, clarification that Medicare refund obligations under the False Claims Act require repayment within 60 days of identification. Now, prior to this, it was a little unclear. If you knew you had an overpayment, did you really have to pay it back? Now it is crystal clear. If you find out from an audit or whatever that you were overpaid by Medicare, you've got 60 days to turn the money back in, or the fact that you keep it becomes, in effect, a false claim, and the funds are now subject to recoupment by the government at treble damages, 3 times the amount. And there's also broader authority to suspend Medicare payments to providers based on credible allegation of fraud or abuse. Okay, so the O&P scorecard on this. Positives, 30+ million Americans, more Americans are going to have health care coverage in 2019. Insurance reforms will reduce coverage and cost obstacles with people with disabilities, particularly as plans move toward essential health benefits. There'll be further benefits if O&P is expressly included in, as I say, in essential health benefits. And there'll be emphasis on outcomes improvement and patient-centered care, which again should be helpful to your industry. Negatives. Medicare reimbursement pressure caused by the annual productivity adjustments are going to make everybody tighten their belts and think more about how to do more with less. The Medicare medical device tax, not clear how it's going to be imposed. Pay or play obligations for those of you that happen to have more than 50 employees, and some coverage reforms will not apply to large group or self-funded plans. For example, very large corporations tend to be self-funded. They do not have to be qualified health plans, and they are not subject to the requirement to offer essential health benefits. So there can, in those self-insured plans, continue to be discrimination against certain benefits. Now, the last category to be determined. What's going to happen with the new Medicare delivery models, ACO and the post-acute bundle, remains to be seen. Effects of comparative research initiatives. How will those be implemented? Will they really affect how care is delivered? Medical loss ratio, insurance premium limits, and the Cadillac tax. What's that going to do to private health insurance as it's offered today versus how it's going to be offered tomorrow? And effects on health care spending, health outcomes, and the overall economy. The CMS has estimated that the share of national spending on health care will actually increase from about 17% now to about 19% in 2019. Obviously, that's because more people are in the system spending more money on health care. But is that a good thing? Is that a bad thing? Remains to be seen. That's the end of the prepared presentation. I think I made it. Couple of minutes for questions, or okay, a couple of minutes for questions. There's 2,000 pages. There's got to be a question somewhere. Sorry I went so fast, but it's a broad topic, and you do have the slides. Okay, no questions.
I have one question.
Oh, okay.
Yeah, just one question. And maybe it was answered in here, but with the Medicaid programs running out of money, what do you feel will be the trend? Will these plans and states go more to the insurance market to cover these in a more cost-effective manner, or are we just going to deal with limited services provided through Medicaid?
Well, I think a little bit of both. I know our neighboring state, Mississippi, is doing the first, which is going toward managed care plans. And I actually worked with a client in that industry, and I was very impressed on how they can pull money out of the system by adopting a managed care model. Some states have already done that. They've wrung the easy savings out. And, for those, I suspect your second option will be what happens is providers will probably take a hit. And that's going to be problematic frankly, for both providers and for beneficiaries, because, if you're going to pay a provider less than it costs to furnish a service, there are not going to be that many people willing to do it, and that means less access, even though the intent was to be more. Yes. And frankly, that's one of the open questions. And probably, honestly, whatever you feel about the bill, whether it gets overturned or not, there will be adjustments. There's so much change. You just can't do all that at once and not have to come back and fine-tune. And I expect in the next Congress, and certainly thereafter, you'll see sort of annual adjustments to this in some fashion.
Thank you. Thank you very much.